So just a brief about myself. I'm Dr. Jeremy Gitau, currently working at the Kenyatta University Teaching and Referral Hospital, as has been shared, and also run this company called Dr. Msafiri. So that's what we'll be discussing today, about Dr. Msafiri, what we do. We look at what is COVID-19, we look what is a vaccine, how they are made. Is COVID vaccine safe? I know that's a question most people have been having. We look at the different types of the COVID vaccine. We'll see how the vaccine is given. And at this point, we'll also look what is the distribution plan for the hospital, for the country when it comes to the COVID vaccine. We look at some of the side effects, and I know this is one of the reasons why some people may refuse to take the vaccine when they hear other people have had other reactions. Then after that, we'll go through a question and answer session. So just by introduction, as I said, that's our hospital, Kenyatta University Teaching and Referral Hospital. I head the accident and emergency and also lead the COVID response team. Briefly about Daktari, what we do is medical concierge. We come to your house. Same services you'll get in the hospital, we bring them to the comfort of your home. We work as a team. We have all those specialists, and I lead the team. And last year we were awarded with the head of state commendation for the work in fighting the pandemic. Those are just a brief about the same. So we look basically at COVID-19. I hope you can all see my screen. So what is COVID-19? We discussed this last time, and we said it comes just from the name coronavirus disease 2019. That's where the name came from. And this is because the virus was, we started seeing patients with the virus in late 2019. That was December of 2019. That's when the first cases were started to be reported in China, in Wuhan state. It's caused by a virus called SARS-CoV-2, and this is very important even when you're discussing vaccines. So all vaccines that are being developed will be developed against this virus, which is the SARS-CoV-2 virus. We said the reason why it's called coronavirus, it's the shape. Someone has. It's the background. It's mainly because of the shape of the virus. That's why it looks like a crown, hence the name coronavirus. So looking at the current statistics globally, we are saying there are about 117 million people who've been infected, and this is about 2 days ago, who've actually contracted the virus. 2.6 million have actually died, but majority have also recovered, and the rest are still receiving treatment in the whole world. This is data from yesterday. That was on yesterday. That was what we saw yesterday. About 479 people turned positive out of the 4,043 samples which were taken. And this means the current positivity rate is at 11.8%. Looking at this, we see that so far in the country we've had 109,000 people who've contracted the virus. Majority have recovered, that is 87,000, and about 1,800 people have died from the virus. If you look to your right, you see that there's actually what looks like a third wave that seems to be starting to come. Actually, a week ago, the positivity rate was way below, less than 5%, and it has remained that way for the last about 2 months. We didn't have any cases. When you talk to most hospitals at the moment, you find that the ICUs are actually full. And this becomes very important because we're able to see, out of the tests carried out, that was yesterday, that was 4,043 tests. 479 people turned positive, which brought the positivity rate to 11.8%. So anytime when you're monitoring the waves or where we are as a country or as, worldwide, we usually look at the positivity rate because it's a better way of telling the number of cases, just that, other than just the absolute number. So we look at the percentage, which is the positivity rate, and this is able to tell us the trend or where we are going. Out of all the samples tested, how many people have tested positive. So we can see now we are at 11.8. I just said about 2 months ago, the positivity rate had actually gone down for the last 2 months, and it was always under, it had remained at less than 5%. Most of the time it was either 2 or 3%. So it's very important for us to notice this and see. If you look on the extreme right, if you, you'll see that the first wave, which was last year around, that was around June to August. That's when we had our first wave. Then the second wave came around October and November last year. That's when we had the second wave, and we had quite a high number of peaks. If you look from 24th, that was about 3 weeks ago. That's when we started experiencing an increase in the number of cases. And these have started to rise, and we're not sure where we'll end. Hopefully the vaccine will have taken place, and we are likely to see fewer cases turning positive. So this is very important, and it's also very important for us even at this time to make sure we are taking care of ourselves, as we discussed, making sure you're wearing your mask, you're maintaining social distance, and you're always washing your hands frequently, either with soap and water or using a sanitizer. Just a brief about the science of the virus. This becomes important because for us to understand the virus, because then we'll understand the vaccines even better. Looking at, as I said, it's a coronavirus. It's part of the family of Coronaviridae, and there are about 40 species across 5 genera. And it's mainly it's a cause of disease in mammals and birds. Humans usually get it as what is called a zoonotic disease, where disease is transmitted from animals to the humans. One thing I can say about SARS-CoV-2 is not a new virus. It's been there. It's actually been about coronaviruses, sorry. They've been actually causing about 30% of common colds that we usually experience, even before we had COVID-19. So it's not a new virus. It's not a new group of viruses, actually. In this group, there are also other viruses, like the SARS-CoV. There's another one called MERS, and if you remember, there was some time back, there were actually outbreaks of the MERS and the SARS infections that lasted only a few months, but also caused a few number of deaths across the world. So it's important for us to know this. It's not a very new virus, and we'll see why this is important when you're looking at the other slide. So looking at COVID vaccine by itself, I would ask if we could proceed with the other slides to the COVID vaccine slide. So why vaccination? And that's the question we always ask. Why do we need to vaccinate? What I can say is that vaccination is a simple, safe, and effective way of protecting people against harmful diseases before they come into contact with it. And what vaccines do, actually they use your body's natural defenses to build resistance to specific infections, making your immune system stronger. So, and what we usually do when we are giving vaccines is we introduce a part or a whole virus that is either dead or has reduced, we'll see. We introduce it to your body, and your body actually comes into contact with them before they get the virus itself. And in so doing, your body develops immunity. And that's the whole science behind vaccination. The aim is aimed at what is called herd immunity, and we'll look at that, because we want to aim at several people having the antibodies that they've created against the disease, and that way the virus is not able to spread, so that even the people who are at a higher risk do not get the virus just because the number of people who have been immune. When you come to the distribution strategy of the country, you'll see we're not planning to immunize everyone. The target is actually 30% of the population, and we believe once we immunize that group of people, then we'll get what is called herd immunity. For most of the time, usually some of the viruses we target up to 70%, but you'll see how the government, through its steering committee, has managed to pre-select who needs to be vaccinated, and hopefully by doing so, we'll be able to fight the virus. So I think the hard question we always ask is, do vaccines work? And as I said, there's something called herd immunity. When you look at herd immunity, it's also known as what is called population immunity, and it helps to indirectly protect us from an infectious disease that happens when the immunity develops either in the population through vaccination or through previous infection. So there are two ways of getting this herd immunity. So you either get it when you get infected, and several people get infected, and then you get herd immunity. Alternatively, people are able to get it through vaccination, and that's what the vaccine is actually targeting. And as I said, the herd immunity does not mean that the people who are unvaccinated or who have not been previously infected are themselves immune. Instead, as I said, it means if they live in a community where there's a high population of people who have the immunity, then they have reduced risk as compared to non-immune individuals living in a community with a small population of immunity. And that's what happened, if you remember, initially, when there was no reported cases in the country. We were all at risk because, one, people did not have the immunity, they had not suffered the disease and survived. So that means the herd immunity was very low, and we were at a population at a risk. And that's why the government actually instilled the measures of testing, of quarantining people, because we knew there was no herd immunity. What I can say is, as people have gotten the virus with time, the herd immunity has started to develop, but it's not at a level where we can actually say that we are all safe. And as I said, in the past, there are several diseases that vaccines have actually worked in developing what is called herd immunity. So if you look at things like polio, rotavirus, pneumococcus, Haemophilus influenza, yellow fever, meningitis, all these vaccines actually are available, and they've actually helped to reduce the number of cases. A case, for example, if you look at a disease like rotavirus, for example, it was causing a lot of deaths in under 5. There are so many children who are dying from diarrheal diseases caused by rotavirus, and just by the introduction of the rotavirus, even to the national, what is called the Accelerated Program of Initiative of Vaccines, that's KEPI, they actually reduced the rates to almost more than 50% by just introducing a vaccine. And that's how the vaccines help. So this is very important for us to know that what we are aiming for with the vaccines is what is called herd immunity. And we'll see how they do the pre-selection. So in case there are any questions, you can let me know. I think for the slides right now, we are quite ahead. I think we are... Any questions so far? We are slide 22. So how are vaccines made? So the question we ask is, one, how are vaccines made? Now that we've seen they actually help. So how are vaccines made? So there are several ways of how vaccines are made. There are what are called live weakened pathogens. By pathogen, we just mean either the bacteria or the virus itself. So you actually take, like now in this case of SARS-CoV-2, as I said, is the virus causing the infection. Then you take the virus, you make it weak, either by destroying it in the... Actually, it gets destroyed, then it goes through the process of making sure that it doesn't cause an infection. It's not infectious, but it's still live. The other way is that they use killed pathogens. That's another way. Then we also have what is called part of the pathogen. That's part of the virus, a small particle, and this is what is developed as a vaccine. The other way is we use genetic material of the pathogen. For example, what is called the RNA or the DNA, and these are what are called nucleic acid vaccines. And as we speak now, this is the way most vaccines are being developed. And in fact, two of the vaccines are actually RNA vaccines, like the Moderna and Pfizer, as we'll see. You can also do what is called a genetic material of the pathogen in a delivery vehicle. So there are some viruses, such as a virus called adenovirus. It's actually injected with the part of the pathogen, in this case as SARS-CoV-2, and then this is tested in the lab, and we'll see through the various phases of how viruses are prepared. And then now this is what actually ends up being developed as a vaccine. These are called vectored vaccine. Actually, the vaccine we ordered is part of what are called vectored vaccines. So this is very important for us to know how the viruses are made. Next. So what are for COVID-19, currently, you can go to the next one. The leading vaccines for COVID have actually come in from 4 parts. Either a whole killed virus, or a virus particle, or nucleic acid vaccines, as I say, that's RNA or DNA, or vectored vaccines. That's the one I was talking about, one of the viruses called adenovirus. The good thing with RNA, which is some of the most common, is that immediately it gets to the body, it's destroyed. Because as you may be aware, our genetic material is DNA. So RNA viruses or RNA material actually gets in. It's not able to do what is called replication, and is not able to actually get into what is called the cell nucleus, which is where most of the cell division and everything takes place in the cell for it to become an active disease. Sorry, today there is a bit of science, but we are at Science Africa, so it's important for us to know all this. The other thing is, as I said, the RNA does not integrate into the human DNA. So these are very important parts when we are discussing the COVID vaccines, and we'll be looking at them. So we're on slide 25. So as I said, these are the different types of viruses that have been developed, either alive attenuated, part of the DNA, or a non-replicating, and those are just the same things as I was briefing you. So we look at vaccine testing. We're on slide 26. Vaccine testing goes through what are called clinical trials. And clinical trials are divided into mainly 2 parts. There's what is called the preclinical, and now the clinical trial itself. Again, the clinical trial is divided into 4 phases. In the preclinical, this is where it is tested in the lab, and this is usually done in mice or apes, and this takes time. Actually, for most vaccines, they'll take 2 to 3 years to be developed in this preclinical trial phase. And then once it's been shown to work in the animals, or that's the mice or the apes, sometimes they even use pigs or any other animals, then once it's working, then it's now taken to the clinical phase, or what is called now the clinical trial. And in the clinical trial, there are 4 phases. So in phase 1, the first thing you want to find out is this vaccine safe in humans? And usually you will take very small numbers. So about 10, you can even take 10 people, and these are the people who are injected with the vaccine. And then it's studied just to find out what is the safety profile of this vaccine. If we give it to people in a large population, what is the reaction that they're going to experience? Then once it's safe and it's been approved, then it goes to the next phase, which is phase 2. And also phase 1, actually all these phases will take about 2 to 3 years to actually get a vaccine approved. So phase 1 completes, then you go now to the next phase. This phase 2, actually what you're trying to do is to find out what is the best dose. You want to find out if I give this vaccine, is it going to produce an immune response in humans? And is this human response, immune response, able to provide the safety that we require and also able to protect human beings from actually the virus itself? And this one now is done on a larger population of people, usually to be in the hundreds, as opposed to the phase 1 where you are doing on a few people, because you already established it's safe in phase 1. So phase 2, you want to find out, is this vaccine actually going to work? Is it going to give us the same results we saw when we did in the lab with the animals? Are we getting a similar immune response? And then now it goes now to phase 3. You want to find out, is this immune response protecting us from the infection? And this is why we now talk about what is called efficacy trials. And this usually happens in more than 1,000 people. And at this point is when now vaccines get registered. And we look at how once we get registered and how they get to work. Once they are registered, then now we can go and do what is called post-marketing surveillance. At this time, you're looking at how the vaccine is working in the population, and the current vaccines that we're experiencing and the current vaccines that we're using for COVID-19, they're actually at phase 4 of the clinical trial. Because this is what now you want to find out. Are there other side effects? Are there other issues that are being experienced that we did not notice during the clinical trials? So just looking at the next slide, you'll see what are called the phases of the clinical trials, as I said. And usually starts as so many drugs. Even for COVID-19, there were actually so many of the drugs that actually were, they tried to put them through the phases of trial. There are actually more than 200. And you'll see about 70% of these are the only ones that actually make it to go to the next phase. And as I said, you're evaluating safety, dosage, and trying to identify the side effects. And so it goes all the way till phase 4. So most of the vaccines that we are currently using are actually on phase 4. They've actually been registered after phase 3 of the clinical trials. So looking at the next slide, we look at what is called COVAX. This becomes very important. I'm sure maybe you've heard of COVAX being mentioned, and we'll see what COVAX does and what it means. One thing about COVAX is actually it's actually being used as the main organization that is helping to drive vaccines. They're actually taking care of about 20% of the vaccines that are going to be distributed in the whole world. And COVAX is actually a coalition between about three organizations. There's an organization called Gavi, which is the Vaccine Alliance. There's Coalition for Epidemic Preparedness Innovations, that's CEPI, and WHO. So, and its aim is mainly to accelerate the development and the manufacture of COVID-19 vaccines and guarantee fair and equitable access for every country in the world. And this becomes very important because this is a pandemic, and we'll see, I'm sure some questions already coming up. We've seen that most of the phases, the clinical trial phases, will actually take between 2 to 3 years. And over a period, if you look at all the phases, actually it takes about 13 to 15 years for a vaccine to be approved for use. But through COVAX, and it's one of the organizations that have actually helped to fasten and to hasten the process of vaccine development. And this is a collaborative organization. So there are several things they've managed to do. As I said, they're taking care of about 20% of the country's population. That's the whole world. They've actually, before, it's not a very new thing. They've managed various vaccines in the past, and they're able to deliver them as soon as they're available. So one thing that happens is once the vaccine has completed phase 3 trial, it actually goes through now. The manufacturer has to maybe target whether they want to make their profits. But now with COVAX, they're able now to distribute it. Immediately it's been approved and it's been registered, then it ends up being distributed to other to other countries. And this has helped also to reduce the acute phase of the pandemic and also rebuild the economy. So COVAX is very important for us. As you may be aware, there are actually about 3 vaccines that have actually gone through the whole process of the clinical trials, and they've been all successful. I think recently there were others that were registered. There's one from SJ, that's Steven Johnson. So they recently registered one, Johnson & Johnson, sorry. They registered a vaccine as well, and it's not yet available in the COVAX, among the COVAX vaccines. So the ones that have been approved through the COVAX are the Moderna and the Pfizer. The Moderna and Pfizer mostly have been used in the US. That's where most of the people who received the vaccines from late last year, October last year, some of the people were actually receiving either the Moderna or the Pfizer one. In the UK, they've received, UK, Scotland, they've received what is called the Oxford, that's the Astrazeneca vaccine. And all these are all safe. They've all gone through the process, and I'll show you how they did that. And also, for us as a country, we'll see, looking at the next slide, that's slide 31, we'll see why Kenya chose Astrazeneca. And the main reason is the characteristics of the vaccine. So for Pfizer and Moderna, they require you to store them in very cold, in the fridges, in temperatures of less than 0 degrees. And however, this is not achievable in our country, because it was easier for us as a country to actually go through what we currently have and what capacity we have. Remember, we've been given other vaccines. There's already a national program of vaccines. Actually, we have the national store, which has 8 cold rooms with a capacity of about 130 meters cubic for positive temperature cold storage. That's between 2 to 8 degrees. And they also have 2 freezer rooms with a net capacity of negative 20 degrees centigrade. So this was very key when choosing which vaccine to select. Remember, the country didn't choose just the vaccines because some people will say they chose them because of the cost. They think we got the worst vaccine. However, when the country was looking at which vaccine to bring to the country, they considered what was already available in the country and what we could be able to handle and what we could be able to store in our cold rooms. On slide 32, we look at the things I've just discussed, the factors that were considered when requesting for the vaccine. The first thing was the platform. As I said, there are various types of vaccines that are developed. In our country, this time we chose the viral vector, and this was because we had a better understanding of the same. We looked at the regulatory processes. That was the vaccine that have already been pre-qualified by WHO. We didn't just go for any vaccine, but we chose the AstraZeneca one. Then also I said we looked at the vaccine storage and cold chain requirements. That's between 2 to 8 degrees centigrade as what is readily available, or minus 20 degrees centigrade. This is already available in the country. Then the last thing that was looked at was the lowest price, which was, when we looked at all these things, the AstraZeneca one was what was fitting for us as a country. We're on 33, slide 33. So the question comes in, is how come the COVID vaccines were made so fast? And I think this is a question people have been asking and would like answers for. One thing I can say is this is a pandemic. This is not the normal situation where this is a global, there's a lot of global interest, and that's where it all began. As I said, there's already global political goodwill, so priority was given at each stage, hence jumping the queue and increasing efficiency. So people opted to, instead of some of these processes going simultaneous, actually they went in simultaneously. They didn't just finish phase 1, then go to phase 2. They were all working simultaneously, ensuring that as some people are looking at phase 1, other people are looking at phase 2, other people are looking at phase 3. And this is one of the reasons why it went very fast. In less than a year, we had a vaccine. The other thing that enabled us to get a vaccine very fast is that we did not start from scratch. As you're aware, we've had other viruses, such as Ebola in the past, and actually we've had a successful Ebola vaccine developed. So what they did is they used already what are called the existing platforms, like the ones for Ebola, to actually develop this new vaccine. The other thing is that they used new technologies. So before the vaccines were being developed, and it used to take a very long time, but now with the new technologies, it was easier to make the vaccines readily available in a very short time. And this is how the world was able to get the vaccines in a record of less than a year. So looking at all this, what I can say is that the vaccines are safe. So, and people need to be guaranteed and to know that the vaccines actually went through all the processes that they're supposed to go through, all the phases that they're supposed to go through, and no phase was actually skipped. And that answers a question on slide 35, that is the vaccine safe? And that's the question most people will want to know. Was it rushed? Was it, did it follow the course, or what happened? And we've seen on slide 36 that most people have actually received the vaccine, and most of them are global figures. Last week we received our vaccines. That was last week, Thursday at night, and we saw our Director General of Health, that's Patrick Amoth, actually receiving his vaccine as the first Kenyan to receive the vaccine locally. Then we've seen various people, the Pope, President Benjamin Netanyahu, the new president of the US. So all these people have received their vaccine, and they've actually done this not just to show that they're supporting it, but also they take it upon themselves to protect themselves, because they're also persons at risk, they're elderly, and they needed the vaccine. So the vaccine, I would say it's safe. It has thoroughly been evaluated for safety, and it has a good safety profile. So what is the eligibility for vaccination? I know most people want to get the vaccine. Immediately it gets here. Actually, we've been receiving several calls from people who actually want to actually get the vaccine. And we'll see how the distribution plan is. So the first thing is that one has to be pre-registered. Before getting the vaccine, you have to be pre-registered at a particular health center. The second thing is that you must be among the target groups of identified people. And we'll see this when you're looking at the phases of vaccination. The other thing is that you must not have a fever. That's a temperature is supposed to be less than 38. Anyone who has a fever of more than 38 degrees centigrade, or anyone who's had allergies in the past, that's either to eggs or chicken, and not just mild allergies, serious allergies, then these are people who would try and avoid getting the vaccine. The other thing is that they must not have suffered COVID infection in the last 6 months preceding the day of the present vaccination. So this is very key. If someone has suffered COVID in the last 6 months, we are saying let them avoid getting the vaccine for that time. For pregnant and breastfeeding, also is one of the reasons why we would say we'd avoid vaccinating. However, a pregnancy test is not a requirement for one to get the vaccine. And then the other thing is that they must give a consent, either verbal or written, for them to get the vaccine. So on slide 39, we look at the Kenyans distribution plan. One thing, as I said, is it's an expensive affair to distribute. You'll find it's costing the country several billions for it to be successful, and for this vaccine to be distributed. And it has always costed about 6 billion for even other vaccines to be distributed. So what we've done as a country is we've worked with partners, mainly Gavi. They've come in and have actually supported the initiative to distribute the vaccines in our country. And the advantage we have as a country is, as I said, looking at slide 40, you'll see we already had the vaccine depots in the various regions of the country. We had Meru, we had Nyeri, Garissa, Mombasa, Nairobi, Nakuru, Kisumu. All these areas have the regional center, the regional depot, where the vaccines are actually able to be distributed. And as you remember, the president actually helped to launch the distribution that was in Nairobi, where they flagged the trailers taking the vaccines to all these other areas of the country. So this is very key, and this has been very important for us, having the fact that we've had these national and regional cold storage, cold store capacities. We are lucky. There are some countries that did not have any of such an arrangement before, and they've had to start from scratch. Good thing for us, we're already starting on an already established program. People have been given immunizations, and they continue to give. So what was the plan in Kenya? Look, we are on slide 41. As I said, Kenya plans to vaccinate actually 30% of the total population. That's about 15.8 million of the current population of close to 50 million. So, and this is by the end of June 2023. That's the target, and the plan is to do it in phases. Phase 1 was to start in January till June 2021, and it's already started. The next phase is to start in July 2021 till June 2022. And the last phase is from July 2022 to June 2023. So those are the 3 phases. But remember, as I said, initially, there are not many vaccines that have been approved. But as we move along, we'll see that some of these phases will actually overlap. As you'll see the people being vaccinated, some of them are at risk, and we'd require them to get vaccinated earlier. So we believe that even as much as it's only 1 million of the doses that have arrived, with time, their vaccines will actually be available to vaccinate the next groups. So on slide 42, we look at the various phases that the government has actually put up. In phase 1, and as I said, it's because of the limited supply of the vaccine. And the target is actually to reach the critical target groups. And these are frontline healthcare workers or the essential workers. And we'll be looking at who are these essential workers. We're saying people who are working in tertiary institutions, the teachers, all these people need to be vaccinated early, and these are the target population in the initial phase. That's the target of 1.25 million. That was in the phase 1. In phase 2, then you focus on people who are either above 50 years or above 18 years with comorbidities. So these are people who actually who have diseases such as cancer, diabetes, sickle cell disease, chronic lung disease, cardiovascular, TB, HIV. So anyone with any of these comorbidities, then they'll actually get their immunization on phase 2 of the vaccination. And then in phase 3 was looking at populations in what are called congregate settings. That's persons in care homes, prisons, detention centers, shelters, street families, or anyone living in a densely populated informal settlements. So that's the target group. And also people working in entertainment, restaurant and retail, and also in the banking sector. So phase 3, that's the target population. And hopefully by the end of this, that's what we are saying, that 30% of the population will actually be vaccinated. And this will help in getting the what I talked about earlier, the herd immunity. Because if you look at these groups, these are people who actually get to interact a lot with people, or people who are at higher risk, like the doctors or the medics who are in the hospitals, or anyone working in a health care facility. These are people who actually interact with people who are at risk, and they're easily to spread the virus. So if these people get vaccinated and they do not contract the virus, then the people even living out there, they will actually be protected just because the virus is not replicating among the population. And that's what is called herd immunity, as I had mentioned. So those are the phases, and it's not cast in stone, as I said. The target is that as you start phase 1, then you go to phase 2, phase 3. As more vaccines come in, then the phases will actually overlap. So looking at slide 44, you actually see how the vaccine is given. As I said, it's given as an intramuscular injection, that's IM. So you're injected on what is called the deltoid muscle. So actually on your left side, that's the recommended area. On the outer side, you'll actually get the vaccine there. And the dosage is 0.5 mLs. It comes in, so it's actually you just remove it, draw it, and give it to the person. And we usually give 2 doses 8 weeks apart. So once you get the first dose, then you have to get the second dose within 8 weeks. However, in case you miss, we still encourage people, at least within 8 weeks, make sure you get the second dose, because the second dose comes in as what is called a booster dose for the first dose that you got. What are the side effects of the vaccine? So the main side effects, and the most common one, actually what are on slide 46, the flu-like symptoms. So people develop something like a flu, but also people have started complaining of what is called injection site pain. So the place where you get injected, it becomes painful. Some people develop redness and swelling. Some people may develop mild fever, you may feel tired, you may get a headache, muscle pain, chills, and joint pain. So these are the most common side effects of vaccination. The good thing with them is that they occur within the first few days of vaccination, and after a very short time the symptoms resolve. The other important thing is that the vaccine has only been tested in populations of persons above 18 years. So anyone less than 18 years will not be getting the vaccine, as we've seen, because it's not been tested. And that's why we said the pregnant women are also excluded, because the vaccine has not been tested among those population. But however, moving forward, once we finish the phase 4, or as we continue with the phase 4 trial, we anticipate that the vaccine will be available for use among the children. And the last slide is looking at some of the rare side effects. Some of the people actually may develop what is called anaphylaxis, or this is a severe allergic reaction. In fact, what we recommend is immediately a person gets the vaccine, then you have to observe them for at least 30 minutes to see if they're developing these severe allergic reactions, especially for people who've actually gotten allergic reactions in the past, either to eggs and they had these severe reactions, or to chicken, as had been mentioned before. I want to stop there, and at this time I'll take questions from the